Good morning, friends. In continuity of molecular oncology package, this topic of liquid biopsy role in oncology I will be discussing, and then this topic of a presentation is by from Major Dr. M. Beg, Dr. Beg clinical oncology classes for the viewers. The liquid biopsy is backbone of precision medicine. Why? Because over the last decade, the concept of precision medicine has dramatically improved in the field of medical oncology. The patient-tailored therapy has significantly improved all measurable outcomes. So, liquid biopsy, why is preferred over it's a new things which is to be considered is because it is non-invasive first. The repeatability is not an issue. You can make in a many times this test. For third is timely and dynamically monitor the tumor initiation and progression. Prediction of prognosis of tumor, that is also there. And then also by this liquid biopsy help, you can find out the drug resistance. The patient, those who are on a continuous targeted drugs for a cancer treatment, you can find out whether this drug is working or not because due to their DNA profile. Finally, helping the oncologist to change their treatment plan in case drug resistance is there. But there are what are the limitation of tissue biopsy? That's still a gold standard. The tumor biopsy, it's an invasive procedure, may lead to complication. The repeatability is an issue. The result of bias is due to tumor heterogeneity. Some sites cannot be possible due to tumor anatomical location that performing the tumor biopsy. With this serious or with serious and very morbid patient, it cannot be performed. So the standard biopsy, the liquid biopsy, is a quick, comprehensive tissue profile, tumor profile, easily obtained, minimal pain, minimal risk, and contrary to the standard biopsy procedure. Furthermore, the genomic profile of a biopsy tissue provides a tumor picture limited to single point of time, only a snapshot. That is the limitation. Biggest limitation is the tissue in the tissue biopsy, which is still practiced. Quite a fairly large amount it is practiced in compared to the liquid biopsy. Now it is being proved that genetic heterogeneity of a numerous cancer genomics is basically a dynamic process. It may change over a period due to pressure effect of targeted drugs and sometimes because of a tumor inheritance biological behavior. So there is a liquid biopsy role is there. The specificity along the dynamically and timely monitor the tumor progression is the USP of a liquid biopsy. The possibility of repeated test by liquid biopsy can be done and decrease the diagnostic bias from a tissue heterogeneity as already explained. Liquid biopsy detect the circulating tumor cells, cell-free DNA, circulatory tumor DNA, exosomes, and as a source of these are as a source of genomic and proteomic information in the cancer patients. So if you say in the blood of a patient, a normal cancerous patients, those who having a tumor is having erythrocytes, leukocyte, platelet, tumor cells, circulating tumor cells, and then circulating RNA, circulating tumor DNA, circulating non-tumor DNA. These are the things. So what this is created a problem because if you say in the total blood, so if you segregate it rather than taking a blood, as we take a plasma so that you can avoid the erythrocyte, leukocyte, platelet, and then even the tumor cells, because your focus is on the circulating tumor DNA and then circulating RNA you want to investigate. And what you want to investigate, the molecular studies, the point mutation in that, amplification or deletion, translocation, fusion gene, methylation status in the extracted circulatory DNA. In molecular oncology, circulating tumor cells and exosomes used as a tool for a liquid biopsy. So where it is being very useful, that's as a prognostic indicators of appropriateness of therapy, tissue of origin and a biomarker status, treat as an equal tumor type, deciding the targeted therapy, immunotherapy and chemotherapy as well. Liquid biopsy data now being studied for a cancer diagnosis, including the cancer screening, but though it is not approved by the FDA, and most importantly for the prediction of response or resistance to the given treatment, is the USP of a liquid biopsy. Like you see here, the microRNA expression profile of a colorectal liver metastasis as a novel biomarker for early recurrence of after partial hepatectomy. I mean, this in the Science Direct Journal has published in the molecular oncology section this study, and they say this that the microRNA profile, if in the after the raised colorectal liver metastasis, it is raised, and after the surgery, it's almost lowest level, and again if it is rising microRNA, that increase that lead to the they certainly lead to the treating consultant for a worry that there is a definite recurrence somewhere. So that is the the use of liquid biopsy. For these reasons, in the recent year, the new field of oncology research has focused the cancer-driven components that circulate in the bloodstream and monitor the disease during the follow-up. So you see here what are the moving in the blood, the circulating tumor cells as such, circulating microRNA, circulating tumor DNA, circulating exosomes, microvesicles, these are there. So if you see, what we investigate in all these is the chromosomal aberration, methylation pattern, deletion, point mutation, translocation, fusion, RNA expression, so that we can, the pathologist, molecular oncologist, investigate this thing and give you a profile, so that according to that, the new targeted therapy or an appropriate target therapy can be instituted. The apoptotic and necrotic cancer cells release the circulatory cell-free DNA fragments designated as the circulating tumor DNA. Exosomes contain proteins and nucleic acid released by the tumor cells. What is the difference between the cell-free DNA and ctDNA? The primary tumor and metastatic sites are also able to exfoliate a vital cell that once enter the bloodstream is called as circulating tumor cells. Isolation is these tumor-derived component from peripheral blood, and their genomic and proteomic assessment represent a new diagnostic tool that is called liquid biopsy. The initial limitation due to scarcity of a nucleic acid, as well as difficulty in distinguishing between the normal and tumor nucleic acid, because in a blood after normal cells also sheets and die the natural death, and their DNA is also there, and then the tumor cells DNA is also there. So separating them is a real challenge, and enrichment technology is being used here, and it is being helped by the new next generation sequencing technique NGS technologies, which now may accurately detect the genetic aberrations. What is next generation sequencing? Is written next generation sequencing described as a DNA sequencing technology which has revolutionized the genomic research. And one should know that the UP state having two labs at a KGMU and CDRI for the NGS technique. With the help of NGS, an entire human genome can be sequenced in a single day. But what is the problem with it has not yet translated into routine clinical practice. But we know in the COVID period, the NGS was quite comprehensively used for the investigation of that virus. Circulating tumor cells and its detection technique, CTC are shaped from the primary as well as secondary tumor sites. They migrate into circulatory system and are responsible for the development of a distant metastasis. But there are certain problems. Occurring with the circulating tumor cells is found in the blood as low as 1 CTC per 106 to 107 leukocytes, or even a very low number in an early stage disease. So its number is also vary. In the early stage, the lower number, and the higher side you found in the advanced stage. So that is also a problem to find out these circulating tumor cells. Since circulatory tumor cells carries phenotypes and genotype information of a tumor, hence it has been recommended as a new biomarker by American Society of Oncology in 2007. So that the data I have already told, the number of circulating tumor cells. And you see in this picture the circulating tumor cell is star-shaped, only one. And out of so many neutrophils, monocyte, lymphocyte, basophils, eosinophils, and the blood picture. The circulating tumor cells now considered as a known hotspot for breast, prostate, lung, and colorectal cancer. So you must actually remember where these liquid biopsy is very, very useful. There are few cancers like the breast cancer, prostate, lung cancer, colorectal cancer, and you know, in all among these, the targeted therapy has a very, very powerful tool for a treatment. So CTC may also cluster with the fibroblast, leukocyte, endothelial cells, platelet forming aggregate with a high propensity to seed the distant metastasis. But the problem with circulating tumor cells, its detection in a different, its percentage in a different cancer varies. Like in a breast and ovarian cancer, the percentage of 50 to 60% cases of like breast and ovarian cancer you get a CTC. But in non-small cell lung carcinoma, the CTC percentage in the blood is almost detected only in 30% cases. And then you also see the lower concentration ranging 1 in 10 cells in peripheral blood requires enrichment strategy. The implication of ctDNA and CTC is it is suggested the prognosis of prostate and metastatic breast cancer will be a prognosis of metastatic and breast cancer will be poor if a 5 or more CTC detected out of 7.5 ml of peripheral blood. As much as the CTC is present in the prostate and metastatic breast cancer, that will say the severity of a disease. And breast and ovarian cancer patient lacking the ctDNA microsatellite heterogeneity certainly do have a poor prognosis. That information you get by the liquid biopsy. The genetic mutation provides the clue about the tumor behavior with the chemotherapy and its recurrent pattern. Like, for example, in the colorectal cancer, ctDNA decreases after the good surgery, but it is stated to increase once the disease recurrence coming out. Till date, the cell search assay using the antibody-based immunomagnetic and image cytometry is the only test approved by the US FDA. using CTC diagnostic and prognosis test for metastatic breast, prostate, and colorectal cancer. So, clinical implication of ctDNA, tumor DNA, is using as a biomarker for several clinical application in solid tumor. It's always updated snapshot of a tumor capable of reflecting the tumor molecular heterogeneity. I mean, the real-time monitoring you can do with this help of a liquid biopsy of a tumor. So, in every stage, you can take the help of a liquid biopsy. In early intervention, you can diagnose cancer screening and localized disease for determine the risk of recurrence after the treatment. For metastatic disease, treatment selection based on the presence of a biomarker, and the refractory disease determine mechanism of resistance and disease progression and change the treatment. ctDNA can be used to stratify the patient with variable risk for recurrence after the surgery and selecting who can really benefit by the adjuvant treatment and avoid unnecessary therapy and targeted therapy precisely those patients, those who are resistant to that, so we can avoid the systemic toxicity. ctDNA is having a half-life is less than 2 hours. Thus, it can be used to monitor the tumor progression real time. So that's the real time picture you can get at that point of time. What is the tumor profile status DNA? Because of a half-life is less than 2 hours ctDNA. However, the percentage of ctDNA in cell-free DNA is very low when compared to 0.01 to 1%, so its detection is a real challenge. The treatment with targeted therapy puts the tumor cell under a selective pressure, thus allowing a clonal evaluation. Therefore, prolonged treatment with targeted therapies can select the cell clone resistant to therapy. What are the limitations? Because the DNA in the peripheral blood is not only contributed to the tumor itself, rather than the normal cell as well. So segregating the tumor DNA is also a challenge. Henceforth, the false positive and a false negative remain an issue like ctDNA in cell-free DNA is that percentage I told you earlier is very low. So detection of ctDNA remains the challenge to overcome this problem. The current researchers started using plasma rather than a blood stream. Furthermore, the ctDNA methylation, such as methylation-specific PCR, is being used. The correlation between the KRAS mutation in the patient with a colorectal cancer and a response to therapy was first demonstrated that there is a gradual increase in KRAS mutated ctDNA in a patient's serum during the prolonged treatment with cetuximab that indicates the resistance is there. It is therefore conceivable that the KRAS mutant clone present in the primary lesion under low pressure selection allow the growth of mutant cells. The exosomes are nano-sized vesicle 40 to 100 nanometer size released by the cells, by the tumor cells, and the detectable most body fluids such as plasma, urine, saliva, acidic fluid. Exosomes are the end product of endosomal pathway and consist of a protein as well as non-coding mRNA, microRNA, either single-stranded or double-stranded fragmented DNA. According to proteomic analysis, several methods have been developed to efficiently collect the exosomes from the body fluids. At present, out of three, the ctDNA and CTCS exosomes, only the self ctDNA having a good prospect in the clinical application, and the European Union has approved the ctDNA testing in ERISA treatment for non-small cell carcinoma in 2014. So I'll tell you about what are the limitations of a liquid biopsy. First, the morphology of CT derived from different tumor tissue is significantly different. Even with a single tumor tissue with morphology, an amount derived like a primary is different from metastatic site. Like in the same tumor, The primary site and the metastatic site have a different CTC pictures. That is the issue. And then, like a different type of a tumor show different in a percentage of CTC in blood circulation. Like I've already told you, in the colorectal cancer and breast cancer patient, the CTC pictures you found only 50 to 60%, but this percentage dropped down 30% in non-small cell lung carcinoma and other tumors because of a low concentration of CTC and ctDNA exosomes. Current technology required to improve because the low concentration it's difficult to detect the genetic mutation and amplification fusion in real time. Second, the cost of next generation sequencing is a matter of concern in clinical practice. The tests are little costlier. The third problem is the sample size. I mean, the liquid biopsy percentage is very, very low in compared to the, I mean, routine gold standard biopsy, tissue biopsy. Almost 1,000, 3 out of 1,000 the data says. First is the public awareness, and the second is the difficulty of a test, and the third is so because the test is being done by the various companies now, the pathology lab, but they are not getting the test for the liquid biopsy. If they are getting 1,000 samples of a tissue biopsy, out of 3 only recommended for the tissue biopsy, for liquid biopsy. Is the only blood sample used for liquid biopsy? Certainly not. The saliva, and for example, DNA methylation pattern for a urine sample in prostate cancer having sensitivity 94.6, even better than the serum PSA. Based on one fact, the saliva can be used as a tool for liquid biopsy as well as using urine for a test for renal and urinary bladder cancer might develop soon. Thank you very much.